Welcome to the Deep Dive, where we sift through the noise to bring you the essential knowledge. Today we're diving into something really fundamental, absolutely critical actually. It underpins pretty much every system in your body. We're talking about calcium homeostasis basically, how your body keeps this vital element in perfect balance. You could think of it as your body's essential utility, crucial for everything from your heart beating to your thoughts firing. Before we get too deep, though, just for you listening, a quick pop quiz. Can you name any physiological or cellular processes where calcium plays an important role? Just whatever comes to mind.
Oh, that's a great question to kick us off. Because calcium, well, it's everywhere, physiologically speaking. You'd probably be surprised. For instance, it's absolutely essential for hormone secretion, muscle contraction, literally every time you move, nerve signaling, and exocytosis, which is how cells release stuff. And that's not all. It's also key in regulating enzyme activity and acts as this critical intracellular messenger, carrying signals inside the cell. It's just pervasive. So our mission today, really, is to equip you, especially if you're, say, a first-year medical student, with a solid understanding of how calcium is controlled. We're going to use some memorable anchors, maybe some metaphors, concepts, just so you can understand, retain, and recall this info, which, believe me, is absolutely crucial for your journey.
Right, and we're focusing specifically on the endocrine control, aren't we? The hormones, and what goes wrong when things get out of whack. So knowing how vital calcium is, it makes sense that its levels are, as you said, tightly regulated. But what does that actually mean, in terms of how it exists in the blood? It sounds like it's more complex than just one number.
Exactly. When we say tightly regulated, we mean keeping plasma calcium within really specific, very narrow ranges. Because even tiny fluctuations can have, well, pretty significant consequences, sometimes life-threatening. Now, calcium in your blood, it's not just floating around as one thing. It actually exists in three distinct forms. Maybe an anchor to help you remember is FBC, free ionized, bound to proteins, and complexed with anions. The free ionized form, CAOS, that's the biologically active one, the superstar, if you like. It makes up about half, 50% of your total serum calcium, and this is the form the body actually monitors and regulates very closely. Then about 40% is bound to serum proteins, mainly albumin, like a little calcium taxi sort of shuttling it around.
Okay, albumin taxis, I like that.
And the final 10% or so is complexed with small anions, like phosphate or citrate, just kind of associated with them. The levels are incredibly precise. Total serum calcium is usually between 2.2 and 2.6 millimoles. But that really critical free ionized calcium, even tighter, 1.3 to 1.5 millimolar.
That's fascinating. So hang on, if only the free ionized calcium is actually doing the work, the biologically active part, why do labs often just measure total calcium? It feels like, for us as future clinicians, we might not be getting the full picture. How do we deal with that?
That is a really critical point for practice. You're absolutely spot on. Only the free ionized calcium drives physiology. Labs often measure total calcium because, well, frankly, it's technically simpler and more widely available. But because so much calcium rides on those albumin taxis, if your albumin level changes significantly, maybe the patient is malnourished or has liver disease, your total calcium measurement will change, even if the active free calcium hasn't.
Ah, okay. So the total number could be misleading.
It absolutely could be. So to get an accurate estimate of the active calcium, you must correct the total serum calcium for the albumin level. There's a standard formula for this. Corrected calcium, measured total calcium, plus 0.02 40 measured albumin GL. That 40 is just a standard reference albumin level.
Got it. So that correction factor basically adjusts for how many taxis are available. Definitely something to remember. Now, here's something to think about, kind of a paradox maybe. We've just stressed how precisely extracellular calcium is controlled, right?
Yeah.
In that tight range. But the calcium concentration inside our cells is kept incredibly low, like minuscule tenoromole compared to the plasma level.
Yeah, it's a huge gradient.
It seems counterintuitive, doesn't it? Given how important calcium is inside cells for signaling and stuff. How does the body manage to keep it so low internally? We'll come back to that puzzle later, but keep it in the back of your mind.
Good point. So let's zoom out now and think about the body's whole calcium supply. Maybe imagine it like a really sophisticated bank account. There are daily deposits, withdrawals, transfers, all happening across several key organs. It's very dynamic. The main vault, holding something like 99% of all your body's calcium, which is about a kilogram, by the way, is bone.
A whole kilogram, wow.
Yeah.
Mostly in bone.
Mostly in bone. But it's not just sitting there passively. It's a living tissue, constantly exchanging calcium with the extracellular fluid. We're talking maybe 500 millimoles a day moving back and forth. Remember, bone is made of proteins like type I collagen, plus that hard mineral part, hydroxyapatite, that calcium phosphate crystal, and you've got cells constantly working. Osteoclasts, which sort of claw away old bone.
Okay, class for clawing.
Yeah, helps remember. And osteoblasts, which are building new bone. It's this continuous remodeling process.
So not just a vault, but a dynamic construction site too, part of that whole bank account balance.
Exactly right. Then you've got the kidneys. They're like the body's highly efficient filters, and they're the main regulators of calcium excretion. They filter a huge amount of calcium daily, something like 10,000 milligrams.
10,000. That sounds like a lot to filter.
It is. But here's the kicker. More than 98% of that filtered calcium gets reabsorbed back into the blood. So ultimately, only a small amount, maybe around 100 milligrams a day, is actually excreted in urine. The kidneys are incredibly good at holding on to calcium.
Okay, very efficient recycling then.
Very efficient. And finally, the GI tract, the gut. That's your absorption department where the daily deposits come in. A typical diet might provide 800 to 1,200 milligrams of calcium per day. Now, not all of that gets absorbed. Maybe around 350 milligram gets absorbed into the bloodstream. But then interestingly, about 325 milligrams is actually secreted back into the gut. So the net uptake, the actual deposit into the body's account, is usually only around 100 milligrams per day.
Huh. So intake equals output, roughly.
Yeah.
About 100 milligrams in from the gut and about 100 milligrams out via the kidneys under normal circumstances. The body aims for that neutral or zero balance.
Precisely. It's all about balance.
But that balance can shift, right? You can have a positive balance maybe during growth or if you really up your dietary calcium. And then the opposite, a negative balance, if you're not getting enough calcium or you can't absorb it well, like with vitamin D deficiency, or maybe you're losing too much, perhaps during lactation or with aging, kidney problems, certain drugs.
Absolutely. All those factors can tip the balance.
Yeah.
And this actually brings us back perfectly to that question you posed earlier. Remember the paradox of high calcium outside cells, but super low calcium inside.
Right. How do cells manage that huge gradient?
Well, here's how they pull it off. It's like a combination of Fort Knox level security and some very active bouncers at the club door.
Okay, Fort Knox and bouncers, I'm listening.
So first, the cell membrane itself is pretty impermeable to calcium ions. That's the basic wall. Second, inside the cell, there are proteins like calbindin that act as cow buffers. Think of them as little sponges soaking up any free calcium, keeping the concentration low. Third, you have the bouncers, powerful active pumps in the cell membrane, like the plasma membrane co-ATPase and the sodium-calcium exchanger. These guys are constantly working, actively pumping calcium out of the cell against that big concentration gradient.
So they're kicking it out even when there's way more outside. Needs energy, I assume.
Oh, yes, definitely needs energy. And fourth, calcium can be sequestered, basically hidden away, inside organelles within the cell, like the endoplasmic reticulum and mitochondria, little storage closets. Now, it's important to remember, intracellular calcium does rise sometimes, transiently, for signaling like in muscle contraction. But it's tightly controlled, because if levels get too high for too long, it can actually damage or kill the cell.
Fascinating. So multiple layers of defense keeping that internal calcium level just right. Okay, we've covered why calcium's vital. It forms the major organs involved. Now let's meet the conductors of this whole orchestra, the hormones. We can use another anchor here, maybe PCC, PTH, calcitriol, and calcitonin.
Great anchor. Let's start with PTH, parathyroid hormone. Think of PTH as the rapid response team leader. It's the main hormone for short-term, minute-to-minute regulation of serum calcium. It comes from 4 tiny glands, the parathyroids, usually found on the back of the thyroid gland in your neck. Inside these glands, the chief cells have these amazing calcium-sensing receptors on their surface. They're constantly checking the blood calcium level.
So they know immediately if it drops.
Instantly. If serum calcium drops, these chief cells get the signal and secrete PTH. If calcium levels rise too high, or if another hormone, calcitriol, is high, PTH secretion gets shut down. It's a classic negative feedback loop. Very efficient. And PTH acts fast. It only lasts about 5 minutes in the blood.
Okay, quick response.
Yeah.
So how does it actually raise calcium levels?
It has a few key targets. Its main effects are on the kidneys. First, it tells the kidneys to reabsorb more filtered CaHo, so less is lost in the urine. Second, it tells the kidneys to excrete more phosphate. That's important because phosphate can bind to calcium and effectively lower the free active calcium level.
Get rid of the phosphates so the calcium stays free. Clever.
Exactly. And third, this is crucial. PTH stimulates the final step in activating vitamin D, creating calcitriol right there in the kidneys. We'll come back to calcitriol in a moment. PTH also acts on bone. If PTH levels are high for a prolonged period, it stimulates bone resorption, breaking down bone tissue to release stored calcium and phosphate into the blood. It does this indirectly by signaling to the osteoblasts, the bone-building cells.
Wait, it tells the builders to signal the demolishers.
Kind of. It binds to osteoblasts, which then release factors that activate the osteoclast, the clawing cells, to start breaking down bone matrix.
Okay, so PTH, fast-acting kidneys and bone are the main targets, brings calcium up quickly. Now, what about calcitriol? You called it the long-term project manager. We had that earlier question, too. How do PTH and calcitriol both raise calcium, but differently? Keep that in mind.
Right, calcitriol. This is the active form of vitamin D, technically 1025 dihydroxyvitamin D. And it's more involved in the medium to long-term regulation of calcium. It's actually a steroid hormone derived from cholesterol. You get vitamin D precursor either as D2 from things like yeast and fungi in the diet, or as D3, which your skin makes using sunlight, or from foods like oily fish. But both D2 and D3 are inactive initially. They need two activation steps, hydroxylation reactions. The first happens in the liver, making 25 hydroxyvitamin D. The second critical step happens in the kidney, stimulated by PTH, remember, to make 1025 dihydroxyvitamin D. That's calcitriol, the active form.
So PTH basically flips the switch in the kidney to make active vitamin D.
Precisely. And calcitriol itself actually inhibits that kidney step, another feedback loop, to prevent things from getting out of hand. Now, an important practical point about vitamin D from sunlight: skin pigmentation and where you live matters. People with darker skin tones have more melanin, which protects against UV damage but also reduces D3 synthesis. So especially in places with less strong sunlight, like northern latitudes, they might not make enough D3 and often need supplements. It's something you'll need to consider when advising patients.
That's a really key clinical point. What about requirements? How much do people generally need?
Good question. In the UK, for example, the general recommendation is about 10 micrograms or 400 international units IU per day for adults and children over 1. Babies need slightly less. And because sunlight is rare in autumn and winter, supplementation is often recommended for everyone during those months and year-round for higher-risk groups.
Okay, so how does calcitriol actually work to increase calcium? What's its main job?
Its primary effect, the main way it increases serum calcium, is by acting on the GI tract. It strongly stimulates the absorption of dietary calcium from your food. This is its major contribution.
So that's the key difference from PTH. PTH gets calcium from bone and kidneys. Calcitriol gets it from the diet.
That's the main distinction, yes. Calcitriol also helps a bit in the kidneys by stimulating calcium reabsorption, similar to PTH. And if levels are very high, it can also contribute to bone resorption, helping release calcium that way too.
So let's tie that comparison together then. PTH versus calcitriol.
Okay, in a nutshell, both raise serum calcium, but PTH is the fast-acting hormone. Its main job is immediate rescue, pull calcium from bones, stop it leaving via the kidneys. Calcitriol is the long-acting hormone. Its main job is to ensure the body absorbs enough calcium from the diet over the long term. PTH manages the account day to day. Calcitriol makes sure there are enough deposits coming in.
Great analogy. Emergency fund versus long-term income. Makes sense. What about the third player, calcitonin, the C in our PCC?
Right, calcitonin. This one is produced by different cells in the thyroid gland, the parafollicular or C cells. It's generally considered the calcium counteragent because its actions lower serum calcium. Its main mechanism is inhibiting those osteoclasts, the bone breakdown cells. It also has minor effects reducing calcium reabsorption in the kidney and absorption in the gut.
Okay, so it does the opposite of PTH and calcitriol, but how important is it really?
That's the interesting part. Despite having these clear actions in theory, calcitonin actually seems to have very little impact on day-to-day calcium homeostasis in humans. Its role might be more significant during times of high calcium stress, like pregnancy or lactation, maybe protecting the mother's skeleton.
So the body seems much more focused on preventing low calcium than high calcium.
That seems to be the case, yes. The machinery to raise calcium, PTH and calcitriol, is much more robust and physiologically dominant than the machinery to lower it, calcitonin. It suggests hypocalcaemia is the more immediate danger the body guards against. And just briefly, while PCC are the stars, other hormones play supporting roles. Sex hormones like testosterone and osteostradiol help maintain bone mass. Their decline with age contributes to osteoporosis. Excess glucocorticoids, like cortisol, are bad for bone and calcium balance. Excess thyroid hormones can also increase bone loss. On the positive side, insulin, IGF-1, and growth hormone tend to support bone formation.
So it's definitely a complex interplay, a whole orchestra, like you said. But PTH and calcitriol are clearly leading the charge. All right, we got the system down. Now, the critical part for clinicians. What happens when this delicate balance breaks? Small changes, big problems, right? Let's look at too much calcium first, hypercalcaemia.
Exactly. When free ionized calcium levels creep up too high, you get hypercalcaemia. And for you, the student, the classic way to remember the symptoms is that mnemonic: stones, bones, groans, moans, and psychiatric overtones.
Kitschy. Okay, what causes it?
The most common hormonal cause by far is primary hyperparathyroidism. Usually it's a benign tumor, an adenoma in one parathyroid gland, just churning out too much PTH even when calcium is high. That accounts for maybe 85% of cases. Malignancy, or cancer, is the next big cause. Some tumors, like breast or lung cancer, can metastasize to bone and destroy it, releasing calcium. Others produce a substance called PTH-related peptide, PTHrP. This mimics PTH at its receptor, causing high calcium, but importantly, it doesn't stimulate calcitriol production like real PTH does. That can be a diagnostic clue.
Interesting difference.
Yes. Also, taking way too much vitamin D can cause it. Non-hormonal causes include things like drinking huge amounts of milk and absorbable alkali, milk alkali syndrome, or certain drugs like thiazide diuretics, which reduce calcium excretion by the kidneys.
Okay, so if calcium gets too high, what does the body try to do?
Well, the high calcium should suppress PTH secretion. Less PTH means less calcitriol production. That should lead to less calcium absorption from the gut, less reabsorption by the kidneys, and less bone breakdown trying to bring the levels down. But in diseases like primary hyperparathyroidism or malignancy, this normal feedback is obviously overridden.
Right. And the symptoms. Let's unpack stones, bones, groans, moans.
Okay. Stones refers to kidney stones, renal calculi, because the kidneys are trying to excrete all that extra calcium. Bones refers to bone pain, increased resorption, and higher risk of fractures. Groans covers abdominal issues like pain, constipation, nausea, vomiting, loss of appetite. Moans relates to generalized symptoms like lethargy, fatigue, depression, decreased alertness.
And then psychiatric overtones.
That covers confusion, memory problems, and in severe cases, even stupor or coma. You might also see things like excessive urination and thirst, polyuria, polydipsia, because the high calcium affects the kidney's ability to concentrate urine. And on an ECG, you might see a shortened QT interval and a slow heart rate, bradycardia.
Quite a range of effects. How's it managed?
First, treat the underlying cause if you can, like removing a parathyroid adenoma. Acutely, management involves aggressive hydration with intravenous saline to dilute the calcium and promote excretion. Then, medications like bisphosphonates, which inhibit osteoclasts, are often used. Calcitonin can be used for a rapid but short-lived effect. Loop diuretics might be used sometimes, but only after fluid repletion.
Okay, that covers high calcium. Now, the flip side. Hypocalcaemia, too little calcium, what happens then?
With hypercalcaemia, the main issue is neuromuscular hyperexcitability. Low calcium makes nerve and muscle cells much easier to fire. You'll want to remember two classic physical signs associated with this.
Okay, what causes low calcium?
A common cause is hypoparathyroidism, meaning not enough PTH. This often happens accidentally after neck surgery, like thyroid removal, if the parathyroid glands are damaged or removed. It can also be autoimmune or genetic. Vitamin D deficiency is another major cause: not enough intake, not enough sun, problems absorbing it in the gut, or kidney or liver disease, preventing its activation to calcitriol. Chronic kidney failure itself impairs calcium reabsorption and calcitriol production. Low magnesium levels are also important because magnesium is needed for PTH secretion and action. And certain drugs, like bisphosphonates ironically, can sometimes lower calcium too much.
So the body's response should be the opposite of hypercalcaemia.
Exactly. Low calcium should stimulate PTH release. High PTH should then boost calcitriol production, increase calcium reabsorption from the kidney, increase absorption from the gut via calcitriol, and stimulate bone breakdown, all to bring calcium levels back up. But again, in these disease states, that response is insufficient or blocked.
And the symptoms, the hyperexcitability.
Yes. It often starts with paresthesia, that tingling or numbness, typically around the mouth, fingertips, and feet. Then you can get muscle cramps and tetany, which is involuntary muscle contraction or spasms. The two classic signs test for this latent tetany. Schwastek's sign is when you tap gently over the facial nerve, just in front of the ear, and you see a twitching of the facial muscles on that side. Trousseau's sign is when you inflate a blood pressure cuff on the arm above systolic pressure for a few minutes. This induces ischemia and causes a characteristic spasm of the hand and wrist called carpal spasm.
Ah, Schwastek's and Trousseau's, key bedside signs.
Absolutely key. In severe acute hypocalcaemia, you can get laryngospasm, spasm of the voice box causing breathing difficulty, generalized convulsions, heart rhythm problems like a prolonged QT interval and tachycardia, and potentially respiratory arrest and death if untreated. Other symptoms can include irritability, anxiety, even personality changes or seizures.
Scary stuff. How do
Yeah.
you manage it?
Again, treat the underlying cause. For acute symptomatic hypocalcaemia, you need intravenous calcium, usually calcium gluconate. For chronic cases, it's typically oral calcium supplements and vitamin D supplements, often the active form, calcitriol, especially if PTH is deficient or kidney function is poor. Magnesium levels should also be checked and corrected if low.
Okay. And finally, just briefly, some specific bone diseases related to all this.
Right. Two main ones related to mineralization problems: rickets in children and osteomalacia in adults. Both are essentially caused by defective bone mineralization due to severe vitamin D deficiency. The bones don't harden properly. So in kids, rickets, you see growth problems, skeletal deformities like bowed legs, weak, soft, painful bones. In adults, osteomalacia, it presents more as diffuse bone pain, muscle weakness, and increased fracture risk. The treatment is replenishing vitamin D and ensuring adequate calcium intake.
And the other big one, osteoporosis.
Yes, osteoporosis. This isn't primarily a mineralization defect like rickets osteomalacia. It's a disease of low bone mass and structural deterioration of bone tissue. The bones become porous and fragile, leading to a much higher risk of fractures, especially the hip, spine, and wrist. It's very common, particularly in older adults and especially women after menopause due to the drop in estrogen. But low calcium intake, vitamin D deficiency, and certain conditions like hyperparathyroidism or long-term glucocorticoid use can also contribute. Management involves lifestyle measures, exercise, calcium D intake, medications to slow bone resorption like bisphosphonates or estrogen therapy, and sometimes agents that stimulate bone formation. So, wrapping it all up, what's the really big picture here? I think it's that calcium is absolutely vital, and its levels are kept incredibly stable by this complex, multi-layered system. You've got short-term fixes, mainly PTH acting on bone and kidney, and longer-term strategies, mainly calcitriol boosting dead absorption. It's all about balancing intake, excretion, and storage. And when that balance fails, whether it's hypercalcaemia or metabolic bone diseases like rickets or osteoporosis, the consequences can be really severe. It just underscores how fundamental this system is.
Absolutely. And for you listening, as you move through your medical training, understanding these mechanisms isn't just, about memorizing pathways or hormones. It's really about seeing the connections, how this one single ion, calcium, ripples through the whole body. It's about being able to recognize the signs when that balance is off, subtle or obvious, and knowing the fundamental principles behind trying to restore it for your patients. And here's a final thought to leave you with. Given how incredibly tightly regulated free ionized calcium is, and the really serious consequences we've discussed when it's even slightly out of range, what does that tell you about the body's absolute priorities? And how does understanding that level of required precision maybe change how you'll think about patient care when you are eventually faced with one of these imbalances? That's our deep dive for today. Keep digging, keep learning.